So we're going to start, like I said, we're going to talk about the second trimester of pregnancy. Is a key aspect of pregnancy and a very important aspect of it. And these are sometimes we refer it to as the honeymoon period because most of the early symptoms that you were having, probably nausea, or the vomiting and the fatigue, um, usually get better. So you get better. And so the mommy is now recovering. We call it honeymoon, basically. They are improving, but there will be other changes that they have to know. It's also a place where we have the rapid fetal growth. So this baby is growing, rapid fetal growth. Um, and then that rapid growth can affect certain hemodynamics, certain features of the mother, right? Um, it's going to create things that the mommy has to also compensate for. So, but this is very important information. And then there will be a lot of maternal changes because of the rapid growth. So it's an honeymoon period as the mommy get adjust to the baby growing too fast. The first one is cardiovascular. I talked about this last time. There's going to be increase in blood volume. And the increase is not just a little bit, 50%. That's a lot. That's a lot of blood volume mommy has to compensate for. She has to figure out how to, all of a sudden, if her blood is like 5 liters, then there's increase. Another 2.5 liters of blood she has to compensate for. And so this is designed to support the baby, right? To support the baby as much as possible. And then also um, provide some oxygenation for the baby to grow. Think about it. If mommy blood volume increases by 50%, what do you think is going to happen to the mother? Apart from what cardiovascular information will will manifest based on increase in blood volume about 50%. What do you think? If I increase your blood volume right now by 50%, what is going to happen to you? Hypertension. So this is why we have to worry about gestational hypertension, right? So we got to check the mommy um, blood pressure to make sure this is not happening. So you have to, this is the NCLEX tips here right away. So you got to watch for either the mommy have gestational hypertension or they have preeclampsia, right? Those information comes in or they develop eclampsia. So this is where everything just start manifesting. I mean, because of this, the increase in blood volume. The increase in blood volume, look, if I give you another 2.5 liters into your blood, what do you think is going to happen to your hemoglobin? What is going to happen? For physiologic anemia. So anemia is common in pregnancy. That's another thing. Don't fall for it. Most of the time we give the mommy iron. But if it's very, very severe, yeah, you got to pay attention to that means mommy is not doing well and we have to do something else. And so this is very important. If you see anemia is common, just iron. And then remember that iron will cause constipation. So when they give you a question, somebody's anemic, you give it iron, think about them asking you about constipation. How do you deal with it? So there's a physiological anemia due to decreased hemoglobin. It's not like mommy is bleeding, it's decreased hemoglobin. So that's the key. If it's severe, we got to deal with it. The GI symptoms with that also will happen. Mommy will get number one is heartburn. Heartburn is common. And how does that happen? It's due to hormones, hormonal changes, um, the, in the uterus. So this is hormones. and the uterus pushing on the stomach, uterus pushing on the stomach. And so that will cause heartburn. And you know how to treat it, right? Small, frequent meal at the time, or they should not lay down right after meal. So avoid laying down right after meal. I mean, you got to raise your head up at least 6 inches with the pillow. All these things you know from other GI, you can bring it. So this is common. It's common in pregnancy. The second one is constipation. I already told you about it. It's due to hormonal changes, mommy. There's going to be, this is mostly progesterone. And these lead to slow peristalsis, right? Every time you see constipation in NCLEX, what should come to your mind? How are you going to treat it? It will be education question or intervention question. Either way, select or apply. So, what do you think? Bulky stool. So, what is bulky stool? What are you going to do to bulky the stool? Fiber. So, give the mommy some fiber. So, high fiber diet. So, fiber diet. If you see metamucil or psyllium, some people have had this as a pharmacology. Don't say, oh, I don't know this. That's it. That's it. That's exactly it is. This is psyllium is a fiber medication you give to the mommy to improve the stool to become bulky. They will give the word bulky agent. It's also okay. Same thing. That's pharmacology. But you can't do bulky agent without what? There's no way. Fluid intake, right? So fluid intake. And your test 2 to 3 liters is the good value. And exercise. If you're pregnant, you can exercise. You can dance, you can walk, So that's where you take them. I mean, so those are the things. Hydration, fluid, and that. So these are all GI symptoms that you should be familiar with. Then the urinary system. This is also due to, because of the increased blood flow, the kidney is getting about 80% of that, 80% of the blood. And so your urine output goes up. So, I mean, and if they give you a GFR, glomerular filtration rate increases. One thing that can happen is like UTI. UTI is common. So ask for these symptoms, ask for it, so that we can treat them, I mean, as soon as possible. But it's very common that if they say they're having urgency, sometimes you have to distinguish between true UTI or just due to increased frequency. So be careful in the question. They will have urgency, they will have frequency, but they may not have this dysuria, right? Painful urination. It's different from you got to go all the time, you can't hold it. It doesn't mean it's UTI. So don't fall for these kind of information questions. Just make sure all information mixed UTI. Just because she's having a lot of frequency but fluid doesn't mean urine output doesn't mean she has UTI. And this one is common, right? Musculoskeletal. This is due to ligament. I call it ligament relaxation due to progesterone. This is the hormone. And this is designed to get ready for delivery, right? Your pelvic floor muscle should be get ready to relax and be able to contract. So, but in the process, it can cause back pain. And you get something lumbar doses, right? A loss of due to loss of center of gravity of the mommy change. So center of gravity. So they will be leaning forward with the hunchback, right? And that's what is going to happen. But this is all adaptation to be able to help with the baby. You can tell them to do Kegel exercise to improve their pelvic floor. And then you teach them about posturing. It's very important, good posture. Any questions? But this is the little things due to the all related to blood volume. that you can see in the select or apply, you have to intervene. These, because of the increase, like I said, increase in blood volume about 50%, all this will be related. Mommy is going to, there will be maternal physiological changes. It's good to know what is normal and what is abnormal, and that will help you when they give you a question. You don't have to struggle. Well, I told you there's a lot of fetal growth that is occurring. So week 16 and 20. Please, you got to know this. These are little detail that you see it, like which of this you should intervene. I mean, you have to know them. Who knows one thing that happened between 16 to 20 weeks? Very, very important. The heading tells you fetal growth. What do you think? As soon as you get to 16, 20 weeks, what is the first thing we'll be doing? 16 to 20 weeks. One thing that we want to know. Movement, excellent. So we got to figure out whether the baby well being, and we call it quickening. This is the movement of the baby felt by the mother. That's what we call a quickening. You have to know these specific 16 to, there was some book will say 15 to 20 weeks, but that is the key. And so you have to educate the mother about this movement. The certain movement, if the anklets, this is anklet step. So what are movements that you should intervene, or you should teach them to tell you to call you back? Unfortunately, these are specific, so you have to like know exact numbers. What do you guys think? If there's less than 10 cakes in 2 hours, you should call. If no cakes in 12 hours, you should call. The mommy should know that cakes increases with after she eats, right? With food. So when she add meal, it's going to go up. And this is going to occur same time of the day. The baby knows. So that's something that you have to know. So it's very, very important that when there's these cakes, you got to intervene. But they have to know that when they eat, there's going to be more cakes. So that is expected finding. So if there's no movement in 12 hours, I need to know. Okay. And these are some of the things you see in the test, and they'll try to figure it out. This is the main thing that 16 and 20 weeks that they may ask you. After that, the week 20 to 22, what happened? One important information. What do you think I'm going to do? 20 to 22 weeks. The glucose is usually later. So this is where we check for the fetal tone, right? Fetal heart tone, you should be able to see at least, I mean, so we use something we call fetoscope, right? To look at the heart tone. And then usually you get like 120 to 160 beats per minute. It's normal for the baby. Um, you may start seeing lanugo. These are primitive to warm the baby. And you can see vernix, right? These are, as soon as you see the baby is maturing. The vernix is like the protective coat on their skin. This is protective um, coat on the skin to protect them and to warm them up. And this is also primitive air. That's why anorexia people usually have this in their body, right? So this is very, very important. That's when they start to develop that. What would they, when you see this, what does that mean? Ankle steps here indicate baby is matured, it's maturing. So baby is growing. Okay, it's growing. When you get to the 24 week, week 24, now remember anything less than 20, is the baby has not matured yet, but it's slowly mature. After 24 weeks, um, baby born can survive. Why? Even though it's a preterm baby. So what do you think happened at the 24 weeks? Why baby born 24 weeks, after 24 weeks or at 24 weeks, they can survive, even though they preterm, but it will be a long ride. Why is this so? Mature lung, yes. The lung matures. Why? Why does the lung matures? It's because of secretion of surfactant. This is the key that the surfactant production increases, and then it allow the baby to survive after 24 weeks, and it allow them to mature. So remember, if you born before 37 weeks preterm, even though your lung is mature, you may need respiratory support. So that's, don't forget. The longest 24 weeks is good. I don't want, nobody want to be born at 24 weeks, but it's a clue that the lung has enough time to mature, but it's not perfect, right? It's not perfect. This is also key. Now, prenatal care, routine prenatal care. So these are the few things we talk about is a little high note you're supposed to know. They're going to come to your house clinic, and there's certain things you have to teach them. Weight, okay, weight. I always talk about weight because it's very important, and they ask you, and you can mix it easily. There's going to be weight, so weight gain or loss. Last time I told you, first trimester, everybody is going to gain 1.1 to 4.4 pounds, no matter your BMI. But a second trimester is different. It's based on your BMI. So if you're underweight, that means your BMI is less than 18.5. How much weight should you gain per week? I want you guys to know this specifically so that you can calculate how much the lady should gain in during the second trimester, so that when you see a question, you don't mix. How much, if you're underweight, how much should you gain? The key is if you're underweight, you have to gain more. So you got to gain more. And what is more? You should not gain more than 1 pound, right? So the more will be 1 pound, 1 pound per week. So underweight is 1 pound, I guess, one per week, 1 pound per week. So you can calculate within 16, 13 to 16 weeks, you can calculate 1 times 13, basically will give you 13 pounds. That's our maximum that makes you gain. If your ideal body weight, yeah, you shouldn't gain too much, right? Ideal, you can gain 0.5 to 0.6 pounds per week. If you can think about it. If you overweight, you got to go 0.6, right? Pounds per week. If you are obese, you got to gain less, so zero point 0.5 pounds per week. And this is the same from second trimester and the third trimester, the same thing. If you know this, you can calculate, but just don't forget these things, little things. I don't know. I mean, why they focus on it too much, because the mommy is going to ask it. And so it's one of those little things in the intervention and then teaching, and then you mix the questions. But she shouldn't, if you know it. I mean, you just have to memorize it or think about it. So if more weight gain, what should you think about? What do you think? It can lead to gestational diabetes, right? You can worry about molar pregnancy, right? It can cause problem. If it's less weight gain, then we think we have intrauterine growth rate and restriction. So more weight gain, we can also lead to macrosomia. And what is the effect of macrosomia? What do you think? All these things, you think about it, like this can turn into a case form, right? I can just change it. How they can give you a case based on weight, and then they'll go through. So we know if you gain weight, it can lead to gestational diabetes or it may be secondary to molar pregnancy, but it can lead to microsomia. What is the biggest problem with microsomia? Yeah, C-section. Well, if in case they're doing vaginal delivery, what will happen? Shoulder, yeah, shoulder dystocia. So that's the baby shoulder will get caught up, and that can lead to that. So that's the key information you have to know. Um, there's something about blood pressure. So the blood pressure is going to decrease physiologically by 5 to 10 pounds. That's why this is why oh 5, yeah. This is why pregnancy patient are physiologically hypotensive. Because of that, what should you not do for a pregnancy patient? They are physiologically hypotensive. Even though the blood volume is huge, physiologically, the blood pressure, when you measure the blood pressure, is low. That's why when we see high blood pressure, we worry about it, that it may be due to something else. But what the idea of physiological hypotension means to you, because it's a good question. They may ask you, pregnant lady came in, she's hypotensive. What do you think? What does that mean? So physiological hypertension, what intervention you should be teaching the mommy about it? The pregnant lady in supine position. No, no supine. Never put them in supine because they're already hypertensive. We make them more hypertensive. So every time pregnancy lady came in, pregnant lady come in, tell them not to be on supine position. Same thing. So you teach them to lay on their side, especially the left side is much better. So that's one key. So if he goes up, yeah. So there's a different kind. There's what we call chronic hypertension. You have to understand chronic hypertension means you have a blood pressure already high before 20 weeks. If your blood pressure goes up, okay, blood pressure up after 20 weeks, now it's called gestational, right? Gestational hypertension. When you have symptoms, it's called preeclampsia or eclampsia. This is the way I summarize this. You don't, I mean, if you watch YouTube, it will be a long video for almost an hour about it. It's simple things to think about it. If the mommy is already have hypertension before they get pregnant, it's chronic hypertension. If the blood pressure shows up after 20 weeks, it's gestational hypertension. If they have symptoms, neurological symptoms, it's preeclampsia. If they have seizures, then it's eclampsia. That's all. It's a good topic for you to know. This is the summary, 2 seconds, that if you see a question and you're able to put out this information, you tell your brain that you know the information. So they're not going to trap you. Like this is the summary of that. And each of them has his own management, what you need to do about it. You have to check the fundal height, right? This so that you got to make sure they don't have like molar pregnancy or anything like that. Who know about the fundal height? This is the pubic bone. I want you to know this. It's very important. There's so many ways they can ask you questions. So at this place, when mommy is less than 12 weeks, you won't see anything. There's no show. So first trimester, you won't see anything. We are in the second trimester. So this is 12 weeks, right at the pubic bone, and this is 20. So most of the time, we'll be able to see something all the way up to here, right? So it can be here, here, up to here. At 36 weeks, it's here. So you can check the fundal height. If they came in and then the fundal height is almost twice the gestational age, you know it's a molar pregnancy. So those are the things but you have to know how to calculate the fundal height based on the pelvic pathology, right? So, and it goes up slowly. 20 weeks is the mark and 12 weeks here. So you should be here like that. Okay. And so if the baby is very small, it's 36 weeks, but it's right here. The fundal height is here. You know that the baby is not growing. If it's 10 weeks and the uterus is way here, you know this is too much. Polyhydramnios. It can be polyhydramnios or it can be multiple gestation or it can be molar pregnancy. These are two things and three things you should know. Like if the uterus is way up there, then either they have too many babies there, or there's too much fluid, or it's a molar pregnancy. That's the way they will ask you the question. Okay. Um, then we got to do something we call some lab work. We call it quadruple, but this no, it's a quadruple screen. They're looking for lab work. Which lab work specifically is very important. So I will put quad screen. But which one usually they test at this stage? It's called maternal AFP, alpha fetoprotein. What disease process are we looking for? See, this is a very quick summary of I don't want you to like bother and like killing yourself. I'm just giving you highlight, which what disease process are we testing there? Why do we need the alpha fetoprotein? Neurotube defect, Down syndrome, chromosomal abnormality, like trisomy 21. Trisomy 21 is this or trisomy 18. If they don't give you, they will give you this is trisomy 21. Right. So that's what we're testing for. So what they will ask you is, okay, what do you see in neurotube defect? What do you see in Down syndrome? What do you see in trisomy 18 in terms of alpha fetoprotein? A good NCLEX question. And the trick is down, you go down with the Down syndrome, right? So I'm going to go down with the Down syndrome, which is trisomy 21. So alpha fetoprotein is down. Chromosomal abnormality, trisomy 18, is going to go up. Neurotube defect, alpha fetoprotein is up. So alpha fetoprotein is very high in neurotube defect. It's decreasing trisomy 21 and it's increasing trisomy 18. Trisomy 21 is the same thing as Down syndrome. So you go down with the Down syndrome, right? Any question? So what are you going to do at week 24 to 28 weeks? What do you think? What are we going to do 24 to 28 weeks? This is what we do the glucose test, challenge test. You have to know the difference, right? There's a 1 hour GTT and there's a 3 hour GTT. What is the difference? What is the difference between 1 hour GTT and 3 hour GTT? 1 hour, no fasting. So you're not going to fast. How much glucose are you going to use? Put that 50 grams. 50 grams. So 50 grams is 1 hour, 50 grams. What value are you going? You're going to check the glucose 1 hour later. What value are you looking for? So we want it to be less than 140. So less than 140 milligram per deciliter is the key. The 30 hours is fasting. You fast, and we give you 100 grams of glucose. And we check you for 1 hour, 2 hours, 3 hours. And still, we're looking for less than 3 hours. If 1 hour fail is greater than 140, or you get 150, you does not have gestational diabetes. It's a trap question. If you do 1 hour and you get 150 milligram per deciliter, it does not mean you have gestational diabetes. You got to do confirmatory, which is the fasting one. Of course, if you do a random and you get like 250, yeah, there's no way. That one is bad, right? And 250 twice, that's a diagnosis of gestational diabetes. But if they get 150, you still have to confirm it with a 3 hour test. Complication associated with it, macrosomia, shoulder dystocia, all these things you got to connect, you got to teach the patient. They will not need insulin right away. They will need management in terms of the diabetes medication. If you get worse, you may need insulin. You have to know how to give insulin. You have to know what type of insulin. You have to know the injection and all the teaching. These are fundamentals. NCLEX is a board exam, so they can ask you so many things. When they give you a case study, you should be open to bring your content to answer that. I don't think anybody can teach you everything about glucose challenge test. So far as you know what is glucose, how to test it, then what do you do? Patient has diabetes now. It's now med search. How do you manage diabetes? Teaching education. If they need oral insulin, you teach them. You have to know the pharmacology. If you need IV, you got to teach them, all of them. What is the complication you're trying to avoid? Baby getting big, leading to macrosomia, and if it is a problem, right? So that's key. Well, every pregnancy, there's complications. So common concern, I call it common concerns in the second trimester. What should you worry about it? You're going to have left cramps. It's not DVT. This is due to large blood volume and the uterus pushing on the legs. It can cause DVT, but leg cramps is common in pregnancy. What teaching do you provide? Elevate the legs. Don't forget. Elevate the legs when you get leg cramps. Make sure they don't have DVT, but the most common is elevate the leg, and they can do some stretching. Stretching is also good to reduce the cramp as much as possible. I told you back pain from what? Loss of center gravity, right? And then we talk about um, posturing, proper posturing, right? What else would you think you can teach them? Supportive footwear is very good. Give them something better to wear, and stretching too. For the back, to stretch the back. The big one is vaginal bleeding. You should try to focus on the key aspect that can happen whenever they have vaginal bleeding. It's due to, this is the way I want to think about it, placental problem. Then you say if it's placenta problem, it can be previa or abruption. And that is the way you can simplify information. First trimester bleeding may be ectopic pregnancy or miscarriage, right? Second trimester bleeding, it may be a placenta problem, which is previa or abruption. Or accreta. Accreta is basically but you see more on the third trimester, right? You see the placenta is embedded in the uterus, and that can cause more bleeding. You should be able to distinguish between these problems um, easily. Previa is mostly painless, right? It's a bright red blood, right, per vagina. That's what it means. And it's most of the time it's due to the placenta occupying the cervical arch. This patient need a bed rest. Need to be resuscitated, some blood, pelvic rest, no sex. And then if they stop bleeding, you discharge them, DC home, and then tell them that hey, if you start having signs and symptoms of labor or bleeding, come back, because we don't want you to go to labor because the placenta is still occupying the cervix. If this is the cervix, placenta, no, the uterus, placenta is covering the cervical arch. And so if you contract, you're going to destroy the placenta. So we want to check if you can have a vaginal delivery or if you're going to have C-section. Not everybody with placenta previa will have C-section. If you get to 37 weeks and they come in and you check the placenta has moved, they have a vaginal delivery. So that's the key. Abruption is going to be sudden. You hear the word sudden onset. They have sudden, painful, dark bleeding, right? Baby's in trouble and they need surgery as soon as possible, but still, you got to resuscitate the mother before we go there. So those are key complaints that can happen. Questions? Of course, other complication. What other complication can happen? Headaches, severe headaches, right? We talk about it. Or visual changes. If you take a Motrin and it goes away, good. But if it doesn't, that's a problem, right? This is most likely is a pre-eclampsia state versus eclampsia. And you have to know, I explained to you, these are what you need to do, seizure prophylaxis, make sure mommy is okay, get them ready. So this is just a quick summary so that you can know what to deal with when you see a question. Any question? Is preterm. Well, preterm is having normal labor before 37 weeks. So you got to know what is true labor versus forced labor. Your board love this. True labor, forced labor, so that you can tell the mommy that you're getting true labor or is a forced labor. What is the difference between them? What is the difference between a true labor and a forced labor? Because you got to teach the mommy. The contraction has to start from your back to the lower abdomen. And it has to occur regular. There have to be cervical changes and effacement. Simple way to go. So you can contract and there's no change. We have regular contraction, things are happening, and it contract, it's causing changes in the cervical. So the mommy have to know. So preterm labor is key things you got to teach them because if it happen, then we have to know. And when preterm, you got to be sure the baby is doing okay. What is your number one thing when it comes to preterm labor? What is your key? And that's the definition of preterm. We got to stop labor, right? So you got to give the mommy something. It's no, you don't give them surfactant. No, we got to give them tocolytic. Stop contraction. That is the key. We got to stop contraction. So anything that slow the uterus, so we're going to stop the uterus from contracting. You can give them calcium channel blockers. You can give them magnesium, whatever you know that it sometimes NSAID or anything that you know that you think can slow down the uterus. That's your key. So slow down the mommy as much as possible, and then figure it out before you can give them surfactant and other thing. But number one, the priority action for a patient in preterm labor is stop contraction. Don't think about anything. Give them tocolytic and slow it down. Of course, all the things we talk about, we have confirmed that mommy has what? Is pregnant. That means we got to make sure there's a presumptive. Your board love this. I mean, and trust me, a lot of people that have told me about this thing is like presumptive diagnosis versus probable versus positive. Well, you have, if you don't want to know anything about before you take your test, you got to know all the different kind of options for presumptive, probable, and positive. And the way I see is presumptive. Mommy is talking. Probable, examined by the doctor. Positive, that means you're using something to look and confirm there's a baby inside. So you're checking for heart tone. You are using ultrasound. It's a positive. Mommy said, my belly hurt. Mommy said, I can feel the baby quickening. Quickening is a presumptive. It's a mommy telling you, right? My breast is enlarged. I feel nauseated. Probable, the doctor examine. So you have the Chadwick sign, Eger sign, Godel, all those Brostin Eek signs. Don't let them confuse you. Those are like a given. You take that point and run away. And the positive, so far as they say, you use something to look for a baby inside the mother, is positive. You don't have to memorize. If you do memorize all the list, they will give you something you never seen before. But if you think about it, they say, Mommy said, I can feel. Mommy do what she said is a presumptive. Doctor examine the patient and feel that the cervix is very thin. Oh, doctor examine is a probable. It went to the ultrasound, and you can use the ultrasound to feel the baby heart. Or we can see a baby inside. We can see baby leg. That is a positive sign. And that's how you can memorize those and use it to answer questions related to that.